Hi everybody and welcome to our module on endometriosis. Endometriosis is a condition where women develop endometrial tissue outside the uterus, so glands and stroma can be found in their bodies in places other than the uterine lining. And the endometrial tissue can occur anywhere, but there are several common and classic locations, and these are easy to remember if you just know a little bit of pelvic anatomy. So if we look at this picture at the bottom right, this is the uterus shown here, and all of these common locations are very close to the uterus where you normally find endometrial tissue. So first of all, the ovaries and the fallopian tubes are a common location. The ligaments that attach to the uterus are a common location. The rectovaginal septum, which is the wall between the vagina and the rectum, is a common location, and so is the pelvic peritoneum, also located near the uterus. No one knows exactly why endometriosis occurs, in other words, why endometrial tissue in some women develops outside the uterus, but there are several theories, and they like to ask you about this in the Step 1 exam. So one of the most popular theories is the theory called retrograde flow, and this theory states that there is movement of menstrual tissue through the fallopian tubes that travels to the ovaries and peritoneum. And this theory explains why endometriosis commonly occurs close to the uterus. The idea here is that the uterine lining is shed at the time of menstruation, but instead of exiting the body, it travels to other locations. Other theories include the theory of metastasis. This states that endometrial tissue travels through the veins in the lymphatic system. There's a theory called metaplasia, which says that endometrium from the coelomic epithelium in development turns into endometrial tissue. The coelomic epithelium is the epithelium lining organs and body cavities, and the theory here goes that some of this epithelium develops into endometrial tissue. And then finally, there's a stem cell theory that says that progenitor cells develop into endometrial tissue. To understand the symptoms of endometriosis, you need to appreciate that the ectopic endometrial tissue is hormone sensitive, just like normal endometrial tissue. This means that the ectopic tissue will grow in the presence of estrogen, and it will atrophy when progesterone is withdrawn at the time of menstruation. For this reason, women who have ectopic endometrial tissue will experience growth, bleeding, and inflammation in the ectopic sites as a result of the hormones that fluctuate during the menstrual cycle. If you understand that, then it's very easy to understand that dysmenorrhea is one of the classic symptoms of endometriosis. Dysmenorrhea is cyclic menstrual pelvic pain, and this occurs because the normal hormones of the menstrual cycle stimulate the lesions of endometriosis to grow in size. Another classic symptom is dyspareunia, which is painful intercourse, and this can occur if there is ectopic tissue near the vagina that can be disturbed during intercourse. And then finally, infertility is a classic symptom of endometriosis. Lesions of endometriosis can occur near the ovaries or fallopian tubes, and through poorly understood mechanisms, this can lead to infertility. And many women who have endometriosis are unaware they have the disorder. They think they just have painful menstrual periods, which can be common even in women who don't have endometriosis. So some women initially present with infertility rather than some of these other symptoms. And it turns out that about 40% of women who present for infertility evaluations are ultimately found to have endometriosis as an underlying cause. So shown on this slide is the classic triad of symptoms of endometriosis, that is dysmenorrhea, dyspareunia, and infertility. Some less common symptoms of endometriosis are shown on this slide. Dyschezia can occur, that's painful defecation. This happens when ectopic tissue is located near the rectum, and dysuria can also occur if there is ectopic tissue near the bladder. The diagnosis can be tricky. The physical exam may be normal. Some women have vaginal tenderness if there's ectopic tissue near the vagina. A classic finding is nodules in the posterior fornix. The posterior fornix is the upper vagina behind the cervix. This is a common location for endometrial tissue that is ectopic in endometriosis. And finally, women who have tissue in their ovaries can have an ovarian mass. When you palpate the uterus, the size should be normal, and this is a very important physical exam finding. If the uterus is diffusely enlarged, that suggests a related condition called adenomyosis, which I'll talk about later in this video. And then finally, some women with endometriosis have a retroverted uterus. This is where the uterus is tipped backwards. You can detect this on physical exam. This may be seen in normal women, but it's more common in women who have endometriosis. And in a board question describing a classic case, they may say that the uterus is retroverted. The definitive diagnosis requires biopsy of a lesion and demonstration of endometrial tissue outside of the uterus. This often requires surgical exploration, which is often done laparoscopically. This type of surgery involves inserting a camera called a laparoscope into the abdomen to examine the abdomen and pelvis for presence of endometrial tissues. When this is done, if there is endometriosis involving the ovary, a classic finding is the presence of a chocolate cyst. There are many causes of ovarian cysts, but a large chocolate-colored cyst on the ovary often suggests endometriosis. The reason these cysts are chocolate colored is because the bleeding creates blood in the cyst, which looks chocolate in color. And this is a picture of a chocolate cyst that has ruptured here. If you Google a chocolate cyst, you'll see many examples of large ovarian cysts caused by endometriosis involving the ovary. A couple of other features of endometriosis: it classically occurs in women of reproductive age. So typically in a board question, this will be a woman with cyclic pelvic pain in her 20s, 30s, or 40s. It improves at menopause and during pregnancy, and that's because in both of these instances, the menstrual cycle stops, and that's what's driving the cyclic pelvic pain. And then finally, women who have endometriosis have an increased risk of ovarian epithelial cancer, which I talk about in another video, but I just want to remind you of that here, and this is a picture of an ovary on the screen here to remind you of the association of endometriosis with ovarian epithelial cancers. I'll finish this video by talking about how you treat endometriosis. So the definitive treatment is surgical removal of the ectopic tissue. This is obviously reserved for women with more severe symptoms. There are a number of drugs that can be used to control mild to moderate symptoms. One thing that can be tried is nonsteroidal anti-inflammatory drugs, or NSAIDs, like ibuprofen. These simply reduce inflammation, and they're sometimes helpful in women who have mild symptoms. For most women with endometriosis, however, in the modern era, the mainstay of treatment is oral contraceptive pills, or OCPs. This is the first-line therapy for most women who have endometriosis. And in order to understand why OCPs work and why some of the other therapies we'll talk about shortly also work, you need to appreciate the fact that the worst thing for ectopic endometrial tissue is the normal menstrual cycle. In the normal menstrual cycle, estrogen goes up and down in the first half of the menstrual cycle, and then progesterone goes up and down in the second half. Ectopic endometrial tissue hates this, and it makes that tissue flare and cause lots and lots of symptoms. So anything you can administer medically that wipes this out will make endometriosis better. So oral contraceptive pills do this by suppressing ovarian function, and the key component is the progestin component of these pills. The progestin component suppresses the ovaries and causes anovulation. In addition, progestins are anti-estrogen, so they limit endometrial growth. So for all of these reasons, you get improvement of symptoms of endometriosis when you place women with the condition on oral contraceptive pills. Another therapy for endometriosis that's less commonly used is leuprolide. Leuprolide is a GnRH agonist. It binds to receptors in the pituitary and downregulates the GnRH receptor. This will desensitize the pituitary so it releases less LH and FSH, and this will decrease estrogen production from the ovaries. And once again, the idea here is that you're interfering with the normal menstrual cycle. Anytime you do that medically, it helps patients who have endometriosis. And then the last therapy I'll mention is danazol. This isn't used much in the modern era, but they like to ask you about it on your board exam. It's a steroid. This is its chemical structure here. You can see that it has the 4-ring steroid structure. It's got weak androgen and progesterone activity. So because of the progesterone component, it will inhibit the LH surge and cause anovulation, just like oral contraceptive pills do. This will suppress ovarian function, and as I've said before, when you do that, you make endometriosis better. In the modern era, this isn't often used, and the reason is because of the side effects, most of which are related to the androgen activity of this drug. So the androgen effects of this drug include weight gain, edema, decreased breast size. Women can develop acne and increased hair growth, and their voice can deepen. So you can imagine that most women do not like to take this drug because of these side effects, and in the modern era, we have the alternative of oral contraceptive pills. In addition, because progesterone is anti-estrogen, there can be low estrogen effects, which can include hot flashes. It's sort of like the woman is going through menopause. And then finally, this drug has an association with intracranial hypertension or pseudotumor cerebri. Some women who take this drug develop headache and papilledema from increased intracranial pressure. So this is just yet another reason why this drug isn't used much in the modern era. A related condition to endometriosis is called adenomyosis. In this condition, endometrial glands and stroma are found in the myometrial layer. This is caused by hyperplasia of the basal endometrial layer into the myometrium. Normally, the uterus has 2 layers. There's the endometrium, which sits on top of the myometrium made up of smooth muscle. What happens in adenomyosis is the basal or bottom layer of the endometrium grows down into the myometrium of the uterus. The classic finding on physical exam in adenomyosis is a diffusely enlarged uterus, often described as globular. This is usually not an isolated problem in the myometrium. It often occurs throughout the myometrium, therefore the uterus is diffusely enlarged. And this is in contrast to pure endometriosis, where the uterus should be normal in size. This can cause 2 major symptoms. The first one is heavy menstrual bleeding, and the second one is painful menstruation. And this often coexists with endometriosis, even though it is a distinct condition. In women with adenomyosis who still wish to have children, medical therapy can be tried using the same drugs that are used for endometriosis, although adenomyosis is often less responsive to medical therapy. The definitive treatment is hysterectomy to remove the uterus. This is a picture of a normal uterus coming out during hysterectomy here on the screen to remind you of that. This is reserved for women who are highly symptomatic and have already completed childbearing. And that concludes our video on endometriosis.